Olá, boa noite a todos. Nós estamos começando aqui mais um ciclo de palestras da Sociedade Brasileira de Filosofia, Analítica. O ciclo de palestras da Sociedade Brasileira de Filosofia Analítica é uma atividade mensal da Sociedade em que integrantes dinâmicos da comunidade analítica convidam pesquisadoras e pesquisadores influentes para falarem sobre sua pesquisa. Com transmissão ao vivo para o YouTube da SBFA, a Sociedade Brasileira de Filosofia Analítica, o ciclo visa reunir nossa comunidade em torno das discussões e pesquisas na área de filosofia analítica. É justamente esse propósito que nós pretendemos cumprir aqui hoje. Meu nome é Sérgio Farias de Souza Filho, eu sou professor de filosofia da Universidade Federal Rural de Pernambuco e professor permanente do programa de pós-graduação em filosofia da Universidade Federal de Pernambuco, aqui no Recife. E hoje nós vamos ter a palestra do professor Justin Garson, da City University of New York, certo? Eu vou começar a falar em inglês agora, já que a palestra será em inglês, e posteriormente o professor Justin Garson irá proferir sua palestra na língua inglesa. Okay? Okay, so now I will start talking in English. And thank you very much, Justin, for accepting the invitation. It is a real pleasure to have you here with us, talking with such a great topic, with your talk, namely your talk Beyond Psychiatry, Rethinking Madness Outside Medicine. Thank you very much, Justin. I think you can start now, and the slides will show up very soon.
Okay. Well, just thank you so much for inviting me, and thank you for having me here. I really appreciate it. Initially, I wanted to talk about what it means to shift from a dysfunction to a function-centered view in psychiatry. But as I went further along in my work, I started to become convinced that the questions that I was asking were really questions about the authority of medicine as such. And in particular, I came to the following conclusion, namely that to advocate for a shift from a dysfunction to a function-centered perspective, and I'll explain what I mean by that, is not to argue for a kind of pluralism within psychiatry, is to reject the authority of medicine over that condition. So to go from a dysfunction to a function-centered perspective with respect to depression isn't to encourage psychiatrists to be more pluralistic or open-minded. It's really to reject the authority of psychiatry over depression. It's a way of saying, why would medicine have any special authority over depression? So my presentation today does build on a body of work that I've done. It engages with problems that I've been working on for a couple of years now. So I'm going to talk a little bit about my existing work and then how this builds on it. So here's a very quick overview. First, I'm going to talk about this core distinction between madness as dysfunction and madness as strategy. I'll give a very brief historical overview of the way that this madness as strategy paradigm has played out in psychiatry. I'll talk about some of the current implications of madness as strategy, and then I'll kind of move on to the topic of the authority of medicine and really think about what it is for medicine to have jurisdiction or authority over a certain mental health condition. And then finally, I'll come back around to my thesis that to embrace this madness as strategy perspective with regard to something like depression is really to reject the authority of medicine over depression. Okay, so over the last couple of years, I've been of the view that there's a certain paradigm in psychiatry that's so deeply entrenched that it's sometimes hard to see it as a paradigm, as a distinctive style of research. And I call that paradigm madness as dysfunction. And the basic idea behind this is that when somebody is mad, it's because something inside of them isn't working the way that it's supposed to. Something inside of them isn't working the way that it should. And I could give you evidence to document how thoroughly entrenched this point of view is in psychiatry, but I won't do that now. But at the same time, I noticed another paradigm that many of the evolutionary psychiatrists seem to be gravitating toward, but that you also see in earlier works in Freud, in Pinel, in Robert Burton, even in the early Greek doctors. And that point of view is called madness as strategy. And the basic idea behind madness as strategy is that when somebody's mad, everything inside of them is working exactly the way that it's supposed to. Everything is working exactly the way that it should. So you can talk about this distinction in terms of function versus dysfunction paradigms, purpose versus pathology paradigms, design versus disease paradigms. And then I wrote a book that depicted all of psychiatry's history in terms of a clash or a confrontation between madness as strategy and madness as dysfunction, rather than, as it's often done, in terms of a clash between biological and psychological points of view. So in my point of view, the distinction that I'm drawing between dysfunction and strategy frameworks completely cross-cuts the distinction between biological and psychological framings. So let me go on to just give a very quick historical overview of the way that this, what I'm calling the madness as strategy paradigm, has played out in psychiatry's history. And I'm going to start somewhat arbitrarily with Robert Burton, who wrote a massive book in 1621, The Anatomy of Melancholy. And Burton states very clearly at the outset that for him, all madness is from God. It all has a purpose, and the art of healing has to do with figuring out exactly what that purpose is. And for Burton specifically, madness really has these two different purposes. It's supposed to punish you for some kind of a sin or vice, but it's also supposed to give you an opportunity for redemption. So I think for him, the kind of paradigm of all madness is the biblical story of Nebuchadnezzar. So you have this king, and he builds Babylon, and he has so much, he's so arrogant. He says, look what I've created with my own hands. And God gets very angry and strikes him with madness for 7 years. And then 7 years later, he has this moment of clarity. He realizes the depth of his arrogance, and then he praises God for helping, for building the city through him. And I think for Burton, that's kind of the prototype of all madness. It's supposed to punish you, but it's also supposed to be kind of a wake-up call to change something in your life. About 100 years later, you have George Chaney. He writes this wonderful book called The English Malady, about melancholy, perhaps an earlier version of what we would call depression, but a little bit different too. Chaney, too, this is 1733, he agrees all madness has a purpose, and you have to figure out what that purpose is. But Chaney seemed to think that the deepest sin was the sin of intemperance or immoderation, eating too much and drinking too much. And he thought melancholy was kind of like God's warning signal to try to get us to turn our lives around before it's too late. Again, about 100 years later, you have a German physician, Johann Christian August Heinroth. He writes this very thick medical textbook in psychiatry, and much of it reads like a pretty ordinary, medical textbook. But about halfway through, he starts talking about this one particular disorder, which is translated to English as insanity with dementia and rage. And he's very clear that this particular illness is not really a normal disorder. Rather, it's kind of a way for the mind to protect itself from a truth or a reality that's too difficult to bear. So the patient enters into a kind of delusional world, but Heinroth thinks those delusions are part of nature's healing mechanism. And he has this wonderful passage which really summarizes his point of view. He says, in the best of cases, this disease acts as a storm which clears the atmosphere, a wholesome desire of nature to cure a perversion through another perversion. And he thought that in those cases, the kind of doctor's job is to allow the disease to run its natural course, and then the patient would get better in their own right. Around the same time, you have the French doctor, Philippe Pinel. He says something very similar in his treatise on insanity. He describes this one particular disorder, intermittent insanity, where it's like these intermittent bouts of psychosis. And he's very clear that he thinks that they have some kind of a healing or cathartic power. And again, for him, this has this profound therapeutic implication that when you're dealing with this particular disorder, you really don't, he thought, you don't want to stifle it with drugs or, bleeding the patient or restraining the patient. You just want to let the thing run its course. Again, about 100 years later, you have Freud, of course. Freud has very much sees purpose, function, adaptation in mental illness. From the beginning of his works, practically, his point of view is that at least most of the mental disorders, say delusions associated with schizophrenia, have a kind of twofold purpose. Their purpose is to prevent certain forbidden ideas from becoming conscious, but at the same time to fulfill those ideas in a kind of distorted or disguised way. He thought you always have to understand the purpose of a delusion before you can treat it. And Freud influenced a whole generation of psychiatrists after him, people like Frieda Fromm-Reichmann. And she was trying to bring some of his insights to schizophrenic patients in the 1930s and 40s. And in her point of view, schizophrenia happens, it's kind of like a retreat from reality. When, the patient has been rejected one too many times, they kind of break from reality in order to protect themselves. And so in her point of view, the whole purpose of the doctor is just to be a kind of kind, accepting presence in the patient's life, so that eventually they would come to trust the doctor and, open up. She thought, schizophrenia, in her view, is just a strategy to protect yourself. And you have to just let the person know they're okay, they're safe. And then in her theory, they're going to come out of their shell. One of her colleagues, Harry Stack Sullivan in the United States, he too saw schizophrenia as a very goal-directed process. He thought it was like a regression to an infantile state. The mind was effectively trying to take these fragments of itself that it had left behind and to reincorporate those fragments into his personality. But again, the big idea that he shares with a lot of these other doctors is the idea that there is a natural course, and your job as a doctor is to kind of help the psychosis or the schizophrenia or the depression to help it reach its natural end. So getting to the 1950s, this point of view, this madness as strategy, was incorporated into the first edition of the DSM, that's the Diagnostic and Statistical Manual of Mental Disorders. And the DSM breaks it down in this way. It has these three major kinds of disorders: the psychotic, psychoneurotic, personality disorders. And each one is described as a kind of strategy for dealing with conflicts, outer or inner conflicts. So, for example, it describes the psychosis or the psychotic reactions in the following way. It said the psychotic reactions are those in which the personality, in its struggle for adjustment to internal and external stressors, utilizes severe affective disturbance, so on, delusions, hallucinations. So again, it's seeing the madness as a coping mechanism, as a way of dealing with certain problems that have come up in your life. So in my view, coming to the present, a core mission of the DSM-2 of 1968, the DSM-3 of 1980, is really to kind of stomp out this madness as strategy perspective and institute a madness as dysfunction perspective instead. So at the very outset of the DSM-3, and then it repeats this, slightly different versions in all of the successive editions of the DSM, it states very clearly that in order for something to be a mental disorder, there has to be some kind of behavioral, psychological, or biological dysfunction. So the idea was to make psychiatry look as much like the rest of medicine as possible. Diabetes, you have a bodily dysfunction. In mental illness, you have some kind of psychological or a bodily dysfunction. So it seems to me that the DSM-3 really should not be read as a kind of biological takeover of the profession, but a way of instituting this dysfunction-centered point of view. Okay, so that's a very brief history of this madness as strategy, but I think it has a lot of relevance for thinking about mental illness today, partly because it gives us such a nice and I think important counterpart to the standard medical dysfunction-centered model, because it suggests that at least some of the things that we think of as disordered or diseased or dysfunctional are actually serving some kind of a purpose, function. They're responding in some way to the perennial problems of life. So I'm just going to run through 4 quick examples of specific mental disorders where I think that this madness as strategy perspective can be helpful and useful. I do have a blog that I keep for Psychology Today. There's the link to it. So I talk about all of these in a lot more detail, and I give a lot of the kind of scientific references. So if I say anything, that you're interested in, you could go to that link and kind of read more about it. So I'll just run through these 4 things. First is depression. Since the 1970s, it's been very common to think of depression as a kind of brain dysfunction, as the result of a chemical imbalance, one's brain, not enough serotonin. But more recently, I think there are psychiatrists and other mental health professionals who are starting to think of depression not so much as a chemical imbalance, but as your brain's designed signal that something in your life is not working out well and needs more attention. It's kind of like your brain's wake-up call that something in your life needs to be dealt with. And in particular, a number of people are starting to think of depression as having the purpose of motivating me to withdraw from a certain life plan or life goal. Now, I don't know if that's true or not. I think it's an intriguing hypothesis. I think that there's some interesting lines of evidence, but if that's right, then that implies that the solution to depression is not always to medicate it. Of course, there's a role for medication. There's always some role for medication if things get bad enough. But the solution would not always be to bombard depression with medication, but to figure out what it's trying to say. Another example where I think the madness as strategy perspective has a lot to tell us is with borderline personality disorder, BPD. So traits associated with BPD often include profound mistrust of other people, having very kind of volatile interpersonal relationships, impulsiveness, sometimes self-harm. And you can often see BPD described in medical context as the result of some kind of a inner dysfunction, maybe a frontal lobe dysfunction, maybe a executive dysfunction. But one point of view that I think is starting to really establish itself is the idea that the traits associated with BPD are better thought of as survival strategies rather than, brain defects. There's some evidence that up to 80% of people diagnosed with BPD have a history of abuse, trauma, or neglect. And if that's right, if you think about it, having extreme mistrust toward other people is a perfectly functional, adaptive way of a strategy for navigating a kind of hostile world. That doesn't mean that those traits are helpful or good now, but it does mean that healing might consist in recognizing that these are survival strategies and recognizing when they've outlived their usefulness. Third of the four examples, delusions, for example, associated with schizophrenia or some types of depression or bipolar disorder. Delusions are bizarre beliefs that don't have any social sanction, that I'm the second coming of Christ, that the government is videotaping me constantly. And you might think, well, clearly, if anything stems from a brain dysfunction, it's having these wildly false or irrational beliefs about the nature of reality. But there are a number of psychiatrists and other mental health professionals really coming back to this much older idea that at least sometimes delusions serve a purpose, a function. They're designed to give the person a sense of meaning, purpose, significance in life. And if that's right, then again, you don't necessarily want to attack the delusions head on, but rather you want to figure out, okay, what are some alternative ways of providing that sense of meaning or significance? And there's a very interesting thing called the insight paradox, which is very easy to understand on this madness as strategy point of view, where when somebody loses their delusions, whether through medication, therapy, whatever, they often sink into a very low mood. They become depressed. And you might think, well, why would somebody get really depressed when they lose their delusions? It's supposed to be a good thing. You're getting better, not worse. But from a madness as strategy point of view, the obvious explanation is that these delusions were playing an important role in giving the person a sense of meaning and significance. And there's a kind of loss associated. They're almost a grief associated with having to lose them in some cases. And then finally, a very different kind of disorder, if you even want to call it a disorder, but it is in the DSM, dyslexia, often described simply as a disorder of reading and writing. But again, there are some cognitive scientists, archaeologists, psychiatrists who are starting to think of dyslexia as an evolved cognitive style in its own right, one that evolved because it benefited individuals and communities. And so, for example, people with dyslexia tend to have some unusual cognitive strengths. They tend to excel at big picture thinking. They tend to excel at what's called divergent thinking, being able to produce multiple solutions to a same problem. These are all very clinically documented cognitive strengths. And if that's right, well, I mean, if that's right, that this is an evolved cognitive style, then this perspective that I'm calling madness as dysfunction is doing real harm to people, because it's fundamentally obscuring the nature of this condition. Instead of seeing it as a distinctive cognitive style with its own package of trade-offs, pros and cons, it sees it as, oh, it's just an inability to read or write, and the student needs all of this remedial help. So those are some ways in which I think the dysfunction-centered framing can be harmful on a multiple levels. I'm actually, I'm going to skip over the material on stigma, but there's a lot of evidence now that these dysfunction-centered medical framings actually tend to promote a certain kind of stigma rather than alleviate stigma, because they give people the idea that my moods, my thoughts, my actions stem from some kind of a defective brain. And it tends to, the idea that schizophrenia or depression stems from some kind of a brain dysfunction tends to make people more afraid of people with schizophrenia. It makes people with schizophrenia seem potentially more unpredictable and more dangerous. Again, a lot of evidence behind these claims. Okay, so I've given you the madness as dysfunction, madness as strategy overview. I've talked a little bit about the historical context, about some of the current day implications. So now I want to come back to the kind of broader philosophical thesis. Initially, when I started working on this, what I took myself to be doing was effectively kind of making a call to medicine to be more pluralistic, to say, look, sometimes it's appropriate to use dysfunction-centered framings. Sometimes it's appropriate to use function-centered framings. So you should be more open-minded and pluralistic about these framings. But as I've gone on into my research, I've started thinking about this project quite differently, which brings me back to my thesis that to advocate for a shift from a dysfunction to a function-centered perspective is not to encourage psychiatry to be more pluralistic. It's to reject the authority of psychiatry over that condition. So take depression. To advocate for a shift from a dysfunction to a function-centered view about, say, depression is not to encourage psychiatrists to be more pluralistic. It's to say, this is not a medical condition. This depression does not fall under the authority of medicine. It's not clear why doctors would be the people to deal with it. And so obviously this claim requires a kind of deeper thesis about this notion of the authority of medicine or the jurisdiction of medicine. So I want to dive into that a little bit deeper. So what does it mean to say that a mental health condition does or does not fall under the authority of medicine or the jurisdiction of medicine? And here's how I think about it. There are a vast number of, I'll just call them unpleasant psychological states that are unpleasant for me to experience or unpleasant for other people to witness in me. So they're either distressing to me or they're disturbing to other people. This could go on and on. Hearing voices other people can't hear, feeling sad for no reason, having a difficult personality, losing interest in sex, drinking too much, feeling guilty because you snapped at your kids, feeling anxious about a job interview, the pain of unrequited love, believing in conspiracy theories, being shy. These are all unpleasant and potentially disturbing. They're either unpleasant to have or disturbing to other people, or both. And there's a kind of broadly shared understanding, both in society and among medical professionals, that some of these things constitute medical problems and others don't constitute medical problems. Some of these things are the kinds of things that it would be appropriate, acceptable, reasonable to go see a doctor for, and others are not really things that are acceptable or appropriate to go see a doctor for. And it's true that that boundary shifts a little bit from culture to culture and from generation to generation. Sometimes something comes to be seen as a medical problem that wasn't seen as one. Sometimes something stops being seen as a medical problem. But everybody kind of recognizes that there is a distinction between those problems that fall under medicine's authority and those that don't. And moreover, people tend to take this distinction very seriously. If you suggest, for example, that something is not a medical problem when it really is, or you suggest that something is a medical problem when it's really not, people tend to get very angry about that. So, for example, if I have a friend who's experiencing the pain of unrequited love, they love somebody, they're not loved back, and they feel devastated by that. If I said to them, you should go see a doctor, you should go see a psychiatrist, they might get very angry. They might say, why would I see a doctor? This is not a medical, painful as it is, this is not a medical problem. They might even feel offended by the suggestion that it is. And there's actually, I think, very deep causes for that, but I won't get into those now. So, given that we have this kind of shared understanding that some problems fall under the authority of medicine and some don't, what exactly makes something a medical problem? What are the qualities that something has to have in order to fall within the jurisdiction of medicine? And one idea that somebody might have, I think it would be a mistake, but just to get something on the table, one plausible idea is that perhaps it's something like this. You could arrange all of these different problems on a kind of scale of disturbingness or a scale of distressingness. And once it hits a certain threshold of intensity, then it becomes a medical problem. But I don't think that that's the right way of looking at it. After all, I've experienced both depression and I've experienced the pain of unrequited love, and I would take the depression any day over the pain of, just the awful pain of unrequited love. But we typically think of depression as the medical problem and not the pain of unrequited love. So there isn't a clear correlation between how intensely distressing something is and our tendency to think of it as a medical condition, as falling under the authority of medicine. So here's my thesis. What makes something a medical problem doesn't have to do with the character of the distress, but the nature of its cause. In other words, to me, the notion of a medical problem and the related notion of the authority of medicine is a causal notion. For something to be a medical problem, it has to be caused in the right way. And so in my point of view, medical problems are kind of like original Van Gogh paintings. In order for something to be an original Van Gogh painting, it's not enough that it looks kind of like it's made in the style of Van Gogh. It has to have been caused in the right way. It has to have proceeded from Van Gogh's own hands. Similarly, I think the notion of a medical problem is a causal notion. It doesn't depend how distressing something is. Rather, it has to have been caused in the right way. And of course, that raises the question, well, how must a problem be caused in order to be a medical problem? I think it has to be caused by what I'll call a violation of a norm of nature. And I don't love that form of words, but I can't do any better at present. So let me just take a moment to explain what I mean. So my claim is that this is part of our socially and medically understood concept of what makes something a medical problem, namely that I think we share this vague idea that in order for something to fall under medicine's authority, it has to result from a violation of a norm of nature. So let me say what I mean by that. All of us kind of vaguely recognize that there are certain ways that the body and mind are supposed to work. There are certain ways they're not supposed to work. Moreover, there's this idea that these norms aren't issued by society, but somehow by nature itself. Nature itself, as it were, declares that there are certain ways that the body and mind are supposed to work and certain ways that they're not supposed to work. And sometimes when things don't work the way that they're supposed to work, that can give rise to some pretty distressing and disturbing consequences. And those are the ones that medicine has authority over. And I've arrived at this condition through three different kinds of routes. The first is just by reflecting on what I understand to be the ordinary ontological commitments of medicine as it's generally understood by society and by medical practitioners. What I mean is that this is the only way that I can think of to roughly distinguish between the things that people do consider to be medical problems and the things that they don't consider to be medical problems. Secondly, when psychiatrists talk about these problems that constitute these, problems of life, these distressing or disturbing phenomena that constitute medical problems, they often appeal rather explicitly to this idea of a norm of nature. So, for example, when doctors describe depression as a chemical imbalance, that's not just a way of saying depression has something or other to do with your brain chemistry. It's a way of suggesting that something in your brain is not working the way it's supposed to. Something inside of you effectively has broken a norm of nature. And then the third line of evidence is historical. When you look back over the history of madness, what you'll find is that almost any time there's been a serious jurisdictional dispute, almost any time doctors have disagreed with other professionals about whether something is or is not a medical problem, they almost inevitably appeal to this idea of a norm of nature to justify their assertion that it is a medical problem and that it does fall under the jurisdiction of medicine. So they don't say things like depression is just inherently upsetting and distressing to have, therefore it falls under the jurisdiction of medicine. They say things like, we have reason to think that depression stems from some kind of an imbalance in your brain or something not working the way that it's supposed to, and therefore it's a medical problem. Okay, so let me just wrap up. Where have I come so far? What I've arrived at is this. To say that something falls under the jurisdiction of medicine, that it's the doctor's job to deal with, is to claim that the condition is caused in a certain way, namely that it arises from a violation of a norm of nature, something not working the way that it's supposed to. Another way of putting it is to say that it arises from a dysfunction. But then that implies that this view that I'm calling madness as dysfunction isn't kind of external to psychiatry. It's not incidental to psychiatry, but it's constitutive of psychiatric thought. In other words, it seems to me now that it would be a kind of contradiction in terms for me to ask a doctor, qua doctor, to stop using madness as dysfunction to deal with the problems that fall under their jurisdiction. That's what it is to be in a sense, that's what it is to be a doctor, to see things through this madness as dysfunction lens. So to me, again, to say that depression isn't a dysfunction, to suggest that it represents, your brain's designed response to the problems of life, is a way of saying that it is not a medical problem, that it does not fall under the jurisdiction of medicine any more than the pain of unrequited love or being anxious about a job interview. So I just want to take about 1 more minute to wrap up, and then I'll be done. So here's just a quick worry that somebody might have. Somebody might say, look, what if we decide that depression really is some kind of functional response of your brain to a life problem rather than a disease or dysfunction? But then suppose we have all these people who are depressed and they're not getting the help that they need. And there's a few things to say about that. First, there are a lot of people whose job it is to help non-medical suffering. There are clinical psychologists, for example, whose job it is to help us when we're suffering, but when we are not suffering because of a medical problem. And that could be really beneficial for 2 reasons. First, if depression really is functional, adaptive, purposeful, then it might be better not to go to a doctor with depression, because you're going to somebody whose whole lens is madness as dysfunction. You're going to somebody whose whole medical training is based around finding dysfunctions and fixing them. And I think in some cases that perspective can actually make people worse off. It can harm treatment outcomes. Now that said, if depression really does have a function, then presumably there could be dysfunctional variations of it. There could be functional forms of depression and then dysfunctional forms of depression. And these would still continue to be medical problems and would still continue to fall under the jurisdiction of medicine. And I think far from being overly complicated, making distinctions like this between functional and dysfunctional forms of depression, just like we make distinctions between functional and dysfunctional forms of pain or fever, making distinctions like this would actually bring a much needed level of clarity and transparency to the way that we deal with and treat depression and other problems. And thank you very much.
Thank you, Justin. Such a great talk. So this is what we should do now. I will ask maybe 2 questions to Justin and Professor Justin Garson, and then I will read some questions from the chat, okay, from the YouTube chat. That will be the Q&A section of this talk, okay? So here we go. Okay, Justin, I was reading the other day some parts of your book, not the new one, the old one, of course, Madness, Philosophical Exploration. And I was wondering about some questions that I think is relevant for the talk today. Oh, maybe not relevant, maybe just clarificatory questions. So, and I will ask now first some of them, okay? Okay, so in this book and in this talk, you make a distinction between 2 approaches to mental illness, right? The one you call madness as strategy. Madness is the working of a hidden purpose, not a defect. This is the first one, madness as strategy, right? It is a goal-driven process, the satisfaction of a certain function. It is to be mad by design. And the other rival approach, madness as dysfunction, is madness is the failure to satisfy a certain function, right? When someone is mad, it is because something has gone wrong in the mind brain of that person. So you have these two different approaches to a certain mental illness, a certain mental disorder, right? And when I was starting looking at it, I was thinking, okay, so what happens that Justin wants to replace one by the other, but it's not the case, right? At least in the book, I don't know if you still, I think you still think in this way right now, right? So what you want to do is with the book, and I think still want to do now, is to glimpse that what we have taken for so long to be the truth of madness, namely the madness as dysfunction approach, is simply a possible mode of interpretation, one among others. So I was interpreting you as being more pluralistic. You can sometimes go with this approach, madness as dysfunction, sometimes to go with the other approach, madness as strategy, right? It depends on case by case or something like that. Okay, so with your reaction, I think I got until now right, maybe not after that. So the first question that I would like to ask you is that I was talking about it with, you should know him, Fabian Hundertmark from Bielefeld in Germany, when we were talking about your book. And me and Fabian, we were wondering that madness as strategy doesn't look as a proper theory of mental disorder. I mean, a full theory of mental disorder from a philosophical, ontological point of view. But it looks like a research program or something like that. So one should not always or immediately assume that there is something wrong going on when considering a mental illness. Sometimes the madness as strategy approach is a better one to be assumed, right? This is something that you argue in the book. It looks to me as fair enough. It's plausible in some sense, in certain cases, etc. But I was wondering, at the end of the day, what really is a mental disorder from an ontological point of view? I was wondering if you assume some kind of ontological pluralism about it. I know that this is not the kind of pluralism that you are attacking here in this talk today. It's a different kind of pluralism. It's striking me at least. So I was wondering, and this is the first question, if you are ontological pluralist about mental illness. So mental illness is something that is either a dysfunction or a strategy, namely in this second case, the fulfilling of a certain goal. Or there is even a third possibility not addressed until now, or something like that. And if you have these 1, 2, or 3 approaches, you think that mental illness is pluralistic in this sense, ontological pluralist in the sense that sometimes it's a function, sometimes it's just a strategy, sometimes maybe even a third case. I was wondering something along these lines, because I think that it is important for approaching certain philosophy of psychiatry's problems, right? What is a mental disorder? What's the relation of mental disorders with other mental states? And some question like that. So I was wondering if you could develop on these questions. Thank you.
Sure, absolutely. Thank you so much. And that's a great question. It's a great couple of questions. The first thing I'll say is that, yes, you're absolutely right. In a sense, I do accept a kind of pluralism of points of view. I think I'll just call them some problems that people have stem from genuine dysfunctions, dementia, for example, and neurodegenerative diseases. Sometimes delusions can come from a neurodegenerative disease. In that case of madness as dysfunction, paradigm would be correct. And I think that function and dysfunction are not just, for me, I'm a realist about function and dysfunction. I don't think that they have to do with our, like a stance that we adopt. I think there's a fact of the matter, whether, say, a person's depression is a functional adaptive response to a life problem, or whether it does stem from a brain dysfunction, a chemical imbalance, a neurodegenerative disease. So I do think that both of those have some role. Some problems stem from dysfunctions and some problems stem from functions, and I think we need to get better at distinguishing them. But I tend to really emphasize madness as strategy so much because almost as a counterweight, I think that madness as dysfunction is so prevalent that in some cases it's almost impossible to see outside of. So if I seem to be really insisting on the value of madness as strategy, it's because I think it is valuable, but not because I think it's universal. But I think it's important to kind of continually insist on this functional perspective because the dysfunction perspective is so deeply entrenched. Now, this is a really good, complicated question that you asked too about how does this distinction between dysfunction and strategy connect with these traditional philosophical debates on the correct definition of mental disorder? Jerome Wakefield and Christopher Borse and naturalism versus normativism, what constitutes a medical disorder versus a non-disorder. And you are absolutely right that the distinction between the notion of madness as strategy is not a theory of mental disorder. It is not a definition of mental disorder. It is a research program. It's a way of, it's a substantive theory about what some of the things that we call mental disorders might actually involve. So when it comes to, yes, but what's the very concept or correct definition of mental disorder, I'm somewhat neutral on that. Now, having said that, I used to be more of a pluralist about the correct definition of mental disorder. I used to think, I used to think that people like Jerome Wakefield were mistaken, that it was too narrow, too limiting to think that mental disorders are, as a matter of definition, dysfunctions. I used to think, well, why would you insist on such a narrow definition of mental disorder? Perhaps some mental disorders are functional and some are dysfunctional. In other words, it seemed like a mistake to define the notion of mental disorder in terms of a dysfunction. But I have to admit, I've started to become more sympathetic to Wakefield's point of view for the following reason. And I've talked to Wakefield a few times and now have a better sense of what he's up to. Somebody like Wakefield, who thinks that mental disorders are by definition dysfunctions, he is not making the claim that depression stems from a dysfunction, that depression stems from a chemical imbalance, that dyslexia is a dysfunction, that BPD is a dysfunction, that delusions of schizophrenia are dysfunctional. He's not claiming that. What he's claiming is that if I'm right about depression, if depression really does serve a function, then as far as he's concerned, it's not a mental disorder at all, and we should stop calling it one. So he doesn't have a stance on whether depression is or isn't dysfunctional. His point of view is that mental disorders by definition are dysfunctions, and therefore, if it turns out that depression actually is a functional, designed, purposeful response to the mind, then we should stop calling it a disorder because that's just confusing. And now I see that he has a point there. Because if I suppose I describe my point of view by saying, in my point of view, depression isn't really a dysfunction, but it's a function. That's one way of conveying this idea that depression is purposeful, not pathological. But here's another way of expressing it. I might just say, in my point of view, depression isn't really a mental disorder. It's a designed response of the mind. So it seems to me that when it comes down to it, the difference between somebody like myself and Wakefield is really more of a subtle conceptual and definitional difference. It's not really a deep disagreement about the nature of depression as such. I hope that that's kind of answered your question a little bit.
No, yeah, sure. When I was talking with Fabian, he mentioned the work of Wakefield that you are sympathetic with. I'm not a specialist on philosophy psychiatry. Fabian is working on it now. His PhD, as you know, was on telesemantics, and that's when we met because I work on telesemantics and biological function, etc. Okay, so thank you, Justin, for your question. I just want to ask a second question before asking some questions from the chat. Okay. And it is very related with these first questions. This first group of questions, actually, right? So if I got you right, we should decide case by case whether to assume the madness as strategy approach or the madness as dysfunction approach when considering a given mental illness. So the first question is: did I got you right? Did I get you right? Is it the case we should access it, the mental disorders case by case? And if so, how we should do it? Do you think that there is some kind of general criteria or criterion that we should assume? Sometimes, and then we can apply it to this criteria to depression, to schizophrenia, BPD, etc. Or there are so many different criteria that you can get to access different mental disorders or mental illness or mental conditions, that whatever you want to name it, that we don't really have a general criteria or general criteria. So I was wondering if you could develop a little bit on this question of how to access case by case whether a given mental disorder should be assessed in light of the madness as strategy approach or madness as dysfunction approach. I hope that my question is clear.
Yeah, absolutely. And that's a great question. There's a conceptual aspect to it in that it partly depends on what exactly you mean by function and dysfunction. So people who have slightly different definitions of function and dysfunction might disagree slightly about how you would go about assessing whether a particular condition is functional or dysfunctional, or functional for some people, dysfunctional for others. So for me, I tend to think about function from an evolutionary point of view. It's not limited to an evolutionary point of view, but that's one very important consideration for me. So for example, if we have some reason to think that, say, take dyslexia, if there's some evidence, archaeological evidence, cultural evidence, genetic evidence that dyslexia is an adaptation, that it evolved at a certain point in human history because it benefited individuals or communities in a certain way, then that would be one kind of broad sphere of evidence from which you would claim it's a function rather than a dysfunction. I think there is some interesting evidence, for example, that ADHD actually may have evolved about 50,000 years ago. I think there's an interesting convergence of archaeological and genetic evidence and so on.
Which mental disorders?
Which I was talking there about ADHD, attention deficit hyperactivity disorder. There's some evidence. Fabian knows about this, that it may have evolved. So that would be one kind of evidence, evolutionary, broadly speaking. Another line of evidence, though, would be more clinical. If you are come to me with depression, and I'm a clinical psychologist, and I try to help you, and we decide, just as an experiment, to look at your depression as if it were purposeful, to look at it as if it were your brain telling you to, say, detach from a certain life goal. And if looking at it that way tends to be therapeutically fruitful, if it tends to make you better, if you say, wow, people have always described this as a chemical imbalance. Now that I'm seeing it as purposeful, I can kind of understand what area of my life it's pointing me to, and I can deal with that. And if that actually helps people get better, then I think that that would be another line of evidence that it's functional rather than dysfunctional. So I think there's a few different ways you might try to assess that. Now, one thing you might do, and I'll say this quickly, is that suppose I think that some kinds of depression are functional and some are dysfunctional, and you come to me and then I'm just not sure which one it is. We might just try. Okay, let's try the least invasive form of therapy first. Let's assume that your depression has a purpose, that it's trying to tell you something, and let's try to figure out what it's trying to tell you. And if a month later, or 2 months later, or 3 months later, we've gone through this and you say, it's not getting any better, it's just getting worse, then we might start thinking of it more in terms of a dysfunction, and we might start thinking about other kinds of interventions. So I think that this is something that's actually a very practical kind of intervention. And I was talking to a friend, Hans Schroeder, who's a clinical psychologist and a professor of psychiatry, who's written a lot about these kinds of function and dysfunction framings. And that's an idea that I kind of got talking with him, that you could actually employ these in a very specific and individualized way. It's not like hopelessly speculative.
I see. It's more practical, right? In the clinic and professionals working on it. Yeah, very, very interesting. Okay, so now I will ask some questions from the chat. Okay, Justin. The first one is from Victor Barcelos, and he's asking, I quote him, what's the meaning of strategy when you claim that madness functions as a strategy? Do you mean that in certain contexts, madness could be a biological adaptation? Thank you, Justin.
Yeah, thank you. That's a really good question. When I first started using those terms, I was trying to look at the history of madness going back to, say, ancient Greek sources, going through medieval times. And I was trying to identify the fact that in some cases, people seem to look at madness as somehow being purposeful. But because they came from such different cultures, from such different eras, from such different belief systems, they had very different attitudes about what the source of purpose is. So if you look, for example, during medieval times, madness is purposeful or strategic because it was sent by God for a certain reason. When you get to, say, the 1800s, madness, some forms of madness might be purposeful because not because they're sent from God, but they represent something like nature's intrinsic healing mechanism, kind of in the way that fever is part of nature's intrinsic healing mechanism. By the time you get to Freud, the purpose of madness is grounded on the idea that madness is a strategy devised by your unconscious mind. Today, in the Darwinian era, yes, I think we tend to think of purpose in terms of biological adaptation. And that's usually, so when I use strategy, I'm trying to use it as broadly as possible to try to encompass all of these different meanings that people have given it over time. But given that we are living in this Darwinian era, when I personally consider this idea that depression might be a strategy, might be purposeful, might be functional, I mean it in an evolutionary sense. It might actually be an evolved, our brain's evolved mechanism for detaching from unrealistic goals. So I think it's important to try to keep both of those kinds of meanings in mind. I hope that's helpful.
Thank you, Justin. So now we have our second question from Luisa Luzzi. And she asks, I quote her, do you think that admitting levels of functionality inside your approach would reinforce this dysfunction stigma? It sounds like you want to distance yourself from that. Yeah, I had the same impression, Louisa, in the talk, right? So, Justin, please, thank you.
Yeah, I mean, the link between function and dysfunction framings and stigma it's very interesting and complex. So initially, there was this idea in the 1970s that the sooner people accept these dysfunction-centered framings, the less stigma that people would have. Because now, if I'm, say, depressed, or I have schizophrenia, or it's not because there's something wrong with my character. It's not because I'm a bad person or I've made bad choices, because something in my brain just isn't working well. And over time, I think that's what we found, is that, yes, there is some alleviation of stigma in terms of that personal guilt, or the idea that depression stems from a character flaw. But the biomedical framings tend to reinforce a very different kind of stigma, where my brain is defective, where I feel pessimistic about treatment outcomes. I feel like I can't do anything about my depression because it's just, that's the way my brain is designed. When it comes to schizophrenia, the biomedical framing can actually reinforce the idea that people with schizophrenia might be unpredictable, might be dangerous. So I do, as much as possible, more and more, it seems to me that is one added benefit to the madness as strategy framings. Not only might they be true, and not only might they be useful, but they might actually be more helpful to people. They might be more psychologically helpful for people and for society in thinking about themselves, how to relate to themselves. Now, I'm not sure if that totally got to your question, because I saw you wanted to ask something more specific about degrees of functionality, but I wasn't quite sure where that part of the question was going.
You mean Louisa's question, right?
Yes.
Yeah. Okay. Okay. We go now to the second question. The third question, pardon, from Beatriz, and she asks, do you think that social norms play a role in how medicine decides what is dysfunctional or not? Can some strategies be considered dysfunctional because the behaviors fall outside the scope of socially accepted behavior?
Yes. Yeah, absolutely. So I think that often enough society deems something to be dysfunctional simply because it's bizarre or strange, or it violates our norms of what counts as acceptable and unacceptable behavior. I think that happens all the time. I think in some ways, when we look at something like the Diagnostic and Statistical Manual of Mental Disorders, we're really looking at it at, not entirely, but to a large extent, we're looking at a catalog of things society finds strange, bizarre, outside of the acceptable social mores. But I think that's a bad thing. I think that's something that needs to be corrected. And part of what my goal is to say, look, function and dysfunction are objective categories. They're real things. There is a real objective fact of the matter as to whether something is functional or dysfunctional, whether dyslexia is a functional cognitive style, or whether it's just a dysfunction, or whether it's a little bit of both. And I think both society and medicine should try as much as possible to align its judgment about function and dysfunction in terms of our best available evidence rather than in terms of, how strange, bizarre, or seemingly outside of social norms this behavior is. So I think you're absolutely right. People do that, and I think it's something we should collectively try to change and base our ideas about function and dysfunction on more objective foundations.
Okay, we still have two more questions, and then I think we can finish it. The second the next one, sorry, is from Victor again, and he's asking, could illness be an adaptation that doesn't provide any positive contribution to today's organismic fitness, similar to wings in ostrich? And then he complements later in the second message. So illness was selected in our ancestors because it provided a contribution to their fitness. But today, illness does not provide a contribution to fitness and could even have a negative impact. That's a possibility, right?
Yeah, absolutely. And I think that's another thing that we would have to look at on a case-by-case basis. So I do think if you wanted to really divide things up more carefully, you would say something like this. Okay, here's at least 3 possibilities with respect to depression. There are more, but here's 3. ADHD is a better example because people are having exactly these kinds of debates with the attention deficit hyperactivity disorder.
Yeah.
One point of view is that it's an evolved cognitive style and it still plays some benefits, has some fitness benefits today. Another point of view, it's an evolved cognitive style, but it mainly benefited our early ancestors when they were migrating around the globe. And today, generally, not always, but it generally mismatched to the needs of society. So it's kind of it had a function, but now it's a vestige of those earlier times. And then a third point of view is that it's just strictly a dysfunction. Your brain is supposed to work a certain way, and ADHD happens when you're maybe a failure of executive functioning or something like that. So yeah, I think that's absolutely a valid and important subcategory of functioning.
Yeah.
Has a function and still performs it, has a function but no longer performs it, is a vestige, and is a strict dysfunction. And then there could be other things. Freckles, birthmarks, they're not functions, they're not dysfunctions, they're just kind of random byproducts of how our bodies are designed.
That's very plausible. Yeah, thank you, Vito. And now we reach our last question, and it's good to have you here, Fabian. I know that's quite late in Germany.
How are you doing?
Yeah,
just talking about you.
Good. Okay, so here is Fabian's question. Hi, Justin. You said that medical problems have to be caused by dysfunctions. Is this causal connection important for you, or could you also accept that medical problems are grounded in dysfunction? What do you think, Justin?
Thanks. Boy, I didn't have any really, it's a good question. I didn't have any very deep thoughts about whether the kinds of problems that constitute medical problems must be caused by dysfunctions, or it can somehow be constituted by dysfunctions. But I was thinking about it in this particular way, and I think that this is the way that the DSM-3 describes it in the successive editions, and the way that people were thinking about it at the time. You effectively have these 3 different things going on when you have a legitimate mental disorder. A, you have some distressing or disturbing complaint. I feel terrible, or I have these strange beliefs, or I'm behaving in ways that society doesn't like. So you have the kind of distressing or disturbing mental phenomena that brings you to a doctor. That in turn is caused by a dysfunction. It's caused by something in your brain not working the way that it's supposed to. And the phenomenon in turn is causing additional problems for you, problems in social role functioning, problems in your ability to get by in society. But yeah, I don't want to insist on that in any very sharp way. I mean, I'm happy to say that in order for, say, depression to be a medical problem, it's not that you have to have these two distinct layers where you have the low mood and then you have the brain dysfunction, and then somehow the brain dysfunction causes the low mood. It could be that the low mood is somehow constituted by a brain dysfunction. So that wasn't a distinction that I was thinking about very deeply, but you're right, and it's an important distinction.
Okay, so I think that this is it. Thank you all for the questions. Thank you all for watching us. And above all, thank you, Justin, for this very nice talk and conversation. It was our pleasure to watch you and the questions and everyone. Thank you, Beatriz and the Brazilian Society for Analytical Philosophy for this series of talks, right? And it is very good. Okay, so I think that we should stop here. Thank you, Justin.
Thank you so much for having me.
Yeah, thank you.